You should get that notification now. Okay, so again, I'll call the order to meeting at 1 p.m. We will just do a quick roll call of members to introduce themselves, since this is our first meeting of the summer. And we've got some different people on the council from last year. So I'll go down the list of agencies and representatives and have you all introduce yourselves. So I'll start off. My name is Megan Carver. I'm with the Office of Planning and Budget. I'm the Division Director of Planning and Strategy and the chair for this council. Next is, do we have anyone from DPH? No. Department of Revenue?
Georgia Steele, Assistant Deputy Commissioner of Agency Operations.
Department of Agriculture?
Good afternoon, Bo Warren, Policy Director with Georgia Department of Agriculture.
Okay. Department of Natural Resources?
Good afternoon, Kate Iannuzzi, Deputy Counsel with DNR.
State Accounting Office?
Good afternoon, Kelly Dudley, Deputy State Accounting Officer for the State Accounting Office.
Secretary of State?
Sam Teasley, Director of External Affairs.
House of Representatives?
Representative Sharon Cooper, Chairman of Health and Human Services, a nurse.
And Georgia Senate?
Ben Watson, Georgia
I
State
know,
Senate,
but it wouldn't pop
Chair
up
of Health and
either.
Human Services, and I'm on vacation, but I'm loving this.
It's connecting.
Well, thank you all for joining us. Very much appreciate it. Just to get us started, I'm going to review the GORRC process, kind of how we're going to conduct each meeting and the content of each meeting, go over the schedule for the rest of the summer, and then we'll get into our work today. So this is a meeting or, council that meets to review legislation impacting licensure, bills related to licensure. So this meeting, we're going to be talking about Senate Bill 643, which has to do with anesthesiologist assistants. While we are going through these three meetings, I want to remind everybody of the 5 criteria that we will be evaluating the bill against. So the first is whether the unregulated practice of the occupation may harm or endanger the health, safety, and welfare of citizens of the state, and whether potential of harm is recognizable and not remote. The second criteria is whether the practice of the occupation requires specialized skill or training, and whether the public needs and will benefit the assurances of initial and continuing occupational ability. The third criteria is whether the citizen of the state are or may be effectively protected by other means. The fourth criteria is whether the overall cost effectiveness and economic impact would be positive for the citizens of the state. And the final criteria is whether there are means other than state regulation to protect the interests of the state. So I'd like to remind everyone that's kind of the criteria that we're using to evaluate this bill. We, during our first meeting, will be mainly informative, where we'll hear from the bill sponsor, the applicant group, and OPB staff to learn about anesthesiologist assistance and legislation behind it. We will then go into public comment, where we'll hear from any interest groups or those interested in the legislation that would like to speak for or against. Then we'll have our next meeting announcement and some housekeeping items, and then we will adjourn. Okay, someone admitted them. So the first meeting, like I said, we'll just go through the background research, hear from those interested parties. The second meeting, we will have any follow-up discussion or answer questions raised during this meeting that we'll need some time to do some background research and address those in the next meeting, and review a draft report Then the third meeting, in our final meeting, we will vote to approve that final report for distribution. Any questions on the process? Okay, great. So we will move into our scheduled discussion. First, we will hear from the bill sponsor, Senator Hufstetler, if you're ready to tell us about your bill and what it addresses.
Yeah, can you hear me okay?
Yes, we can.
Okay, good. I was having a little trouble logging on here. And I'm going to be on probably just a few minutes. I'm actually doing anesthesia at the hospital. But it'll be good because there's a lot of other people I know that are well versed in it. So I am an AA and I've sponsored bills for the PAs and the nurse practitioners. I actually had a study committee that sort of put them on parity and married them together and stuff. But people had said, well, we had never done anything. And I guess the issue is that we are listed as regular PAs, even though it's different training, different programs and everything. It never bothered me. I figured I could just go work as a regular PA in the year on the weekend and make extra money. But just kidding. But anyway, they are quite different in scope. And so a lot of the people in the group, I think there's about 1,200 of us now, felt like we should have our own licensing that isn't, under just the regular PAs, because they are two completely different programs. So this is just an attempt to do that. It's not to change any scope of practice or, anything like that. Just get us where we are recognized for who we actually are and not the regular PAs. There's two schools in Georgia, Emory that I graduated from, South University does it. There is Nova in Florida, different programs, Case Western and Cleveland, Ohio. And it is a completely separate program from many of the regular PA programs. So it's a little bit of a mismatch that we've all been bunched in together. And I think a lot of them in the group would like us to have our own category that more reflects who we actually are. And that's a quick summary of it, I guess. I could take any questions if anybody else.
Yes, Kelly.
So what are the additional benefits to you all besides just separating yourselves because you're trained differently and obviously conduct different work? What are the additional benefits to you and your group?
I don't know that there's any additional benefits because we're still going to do what we do and not do anything different. I know there is one of the issues is having some representation on the composite medical board. That was one of the requests as the regular PAs are on there as well. But I think it's really just more of a being realistic in who we are. We aren't regular PAs. It's completely different jobs that we do, and to say that we are regular PA and can do regular PA work's probably not correct because they've got training and stuff that we don't have, and vice versa.
Thank you.
Are there any other questions for the bill sponsor? Okay, seeing none, thank you so much for your time, Senator Hufstetler. We'll let you get back to work.
Okay, I can hang out for a few minutes, but I'll be leaving shortly. Thanks.
Okay. Next, we'll move on to the applicant group. So I believe that was Peachtree Government Relations and your clients.
Hi, guys. This is Laura Norton. I'm with Peachtree Government Relations, and we represent the anesthesiologist assistants. And we actually have one of our members, Bill Bunton, is going to speak with you guys today regarding regarding this issue. So Bill, if you want to go ahead, I'll pass it over to you.
That'd be great. Thanks, Laura.
Sure.
Can everybody hear me okay?
Yes.
Okay. Hey, I'm Bill Bunton. I'm a licensed anesthesiologist assistant here in Georgia. Practiced anesthesia here since 1996. I serve currently as the volunteer president of the Georgia Academy of Anesthesiologist Assistants, and I'm a member of the Georgia Society of Anesthesiologists as well as the American Society of Anesthesiologists. Georgia's kind of the birthplace of the anesthesiologist assistant profession. In 1969, Emory University anesthesiologists established a training program for AAs that produced anesthesia providers to expand the number of medical cases under sedation at a hospital or ambulatory surgery centers. An AA program in Case Western Reserve in Cleveland, Ohio was started soon thereafter. Now there are over 3,000 AAs in the country. Probably a little over a third of those reside here in Georgia. So we have somewhere between 1,000 and 1,200 AAs in Georgia. So CAAs, Certified Anesthesiologist Assistants, are highly skilled health professionals who work under the direction of a licensed physician anesthesiologist. We're medically directed, and we implement the anesthesia care team with a care plan. CAAs work exclusively within the anesthesia care team model. We cannot work by ourselves. We have to have a physician at the head. Basically, just to go into our education, like Chuck was saying, or Huffstetter was saying, the goal of the education is to guide the transformation of qualified student applicants into competent healthcare practitioners who aspire to work in the anesthesia care team for the benefit of patients. A's have a very specialized education. We spend 27 months, 2,600 clinical hours, 600 didactic hours directly focusing on the practice of anesthesia. And that follows 4 years of pre-med training at a university. PAs have more of a generalized education and often move among a variety of specialties, excluding anesthesia. Although the structure of the training might be similar to AA education, the focus is completely different. PA education and training does not include anesthesia. PAs in Georgia are actually prohibited from practicing anesthesia unless they have attended, graduated from, and are certified as an AA. AAs cannot practice outside of anesthesia unless they have graduated from a PA program. Each had its own separate educational curriculum, separate standards for accreditation, and its own agency for certification. And they also take different certification exams and delivered by completely separate boards. So AAs practice in Georgia as physician assistants in anesthesia. So we're licensed as PAs-A, which again, they're very confusing to the general public. AAs practice and licensure is regulated by the Composite Board of Medical Examiners. The state of Kentucky licenses and regulates AAs under the similar model, but in 15 states, District of Columbia and the U.S. Territory of Guam, CAAs practice under a comprehensive licensure act similar to this SB643 that we're talking about today. 4 states also authorize CAAs practice by delegation of physician authority. The federal government and its its payer systems authorize and reimburse CA treatment of patients in the Veterans Administration and the Medicare and Medicaid networks and in the military. So with the background I've given you, each of you on the council must be asking the question, if CAAs are already licensed to practice in Georgia, why should council members approve an additional regulatory structure? And my answer to that would be that anesthesia is very different than primary care medicine, as well as medically specialty concentrations such as dermatology, cardiology, internal medicine, orthopedics. While current AA licensure approaches worked well under the leadership of the Composite Board of Medical Examiners, our organization believes that because AA training and practice is distinct from that of other physician assistants, the General Assembly should look to approve more comprehensive and specific licensure framework that will be even more protective of patients. So what we've done with SB643 is we've included the best approaches for AA regulation and practice from among the 16 states that are currently licensed AAs. We provide the most comprehensive protection for patients. In other words, SB643 borrows the best language from the other state licensure acts and recognizes the most current training curricula and nationally recognized certification criteria for AAs. It's basically the newest model act for AA practice and licensure. It does not expand CA practice. AAs will continue to practice under the anesthesia care model, where physician anesthesiologists direct and supervise AA administration of anesthesia and the perioperative care of patients in a variety of medical settings. An AA-specific license would allow for increased representation for AAs that would lead to the increased ability to maintain our high professional standards and specific standards for anesthesia. An AA-specific license would also allow for clarity and transparency for patients that need to know a specifically anesthesia-trained provider is taking care of them. That's pretty much my description. I'll be happy to take any questions regarding SB643.
Okay, this is Representative Cooper. Let me get this straight.
Yes, ma'am.
Okay. I don't know why y'all got grouped together with PAs regularly unless you were just a new entity and this was new, and so they decided to lump you with the PAs, because what you're saying and what I know from Senator Hufstetler is as you said, the training is extremely different. You're talking about, if I'm correct, 2,600 hours of supervised experience, right?
Yes, ma'am.
Okay, whereas in the nurse practitioner programs, many of them are online now, and even with Emory, the number of clinical hours they require are 400. It's a very different amount of time and specification, because like you say, if the nurse practitioners and PAs are being trained in a specific area, or if they're being trained in the general area of general medicine, they're getting a big overview, whereas your training is specifically for anesthesia, correct?
Yes, ma'am.
Okay, so it is really almost like a nurse midwife who has a master's level and then other training, very different from a regular nurse practitioner. Okay, I got it. Just wanted to be clear about the difference in the education and how you go about your job. Thank you.
Yes, ma'am.
Can you speak to what specifications of this licensure is changing with this bill, or is it really just modeling after what's currently required of anesthesiologist assistants and formalizing it in state code?
It's basically just formalizing in state code. We will, like the Senator Hufstetler said, we will not change our practice. We're not changing our practice parameters, not changing our scope of practice. We are just separating into our own category. That's all we're doing. We have not added anything that was not currently in the PA Act as it is. Back in 2009 was when we were actually first put in the legislature by Representative Cooper on HB 509. That's when our certification was mentioned. And that's the only line that we're actually in the PA Act. So we're really not described well at all. But we're really not going to change much, except that giving ourselves representation, recognition, and clarity for the public. Does that answer your question?
Yes, thank you.
Well, it certainly sounds like to me, if somebody was deciding they wanted to be, a PA, it seems like to me that this would be, if I said I wanted to be a PA, I would think of it in the overall view of, working as a general practitioner PA or that kind of thing. I don't think I would ever, come up with the idea that I wanted to be an anesthesiologist assistant. I think it might be confusing to students who go into this, into this area. I'm curious about that because, until I began to work with Senator Hufstetler, I'm really not sure that I knew there was this type of category. I always thought that it was just the nurses that went on to get master's levels in anesthesiology, that we had that were doing this. I didn't even know that there was an avenue for young people who want to do this kind of work, that they could go and choose your avenue. They didn't have to go the nursing route or the general PA route. It is confusing.
It is.
At least me, and I have a master's in nursing and know about these things, but it is confusing, and I think it would be very much to young people deciding on a route that they wanted to pursue. And that clarification of this might help that.
Yes, ma'am. I agree.
Do you all know if there's been any documented complaints or, comments from the public as far as the confusion between these occupations and how that's maybe, occurred in the general public? I also believe we might have someone on from the Composite Medical Board that might also be able to speak to that.
Well, generally speaking, from the hospital's point of view, I don't know of any complaints from the public. I don't even know I wouldn't know where those would go. Again, the Composite Medical Board might have more about that. But from a hospital perspective, it's very difficult for AAs and hospitals because we're immediately, when we come in, we're classified as either CRNAs or PAs. They don't even have badges for us. We're still working on name recognition and not having our own license to refer to. And we have to say, okay, you have to refer to the PA license to find us. That's very, very difficult when we're looking to get hired by a hospital.
Daniel Dorsey here, Georgia Composite Medical Board. Can everyone hear me okay? All right.
Yeah.
So in regards to complaints, a lot of the complaints information is confidential by state law, so we can't share details about complaints. But for the most part, I mean, it's the way we classify CAAs is they are like Mr. Button said, that they are considered PAs in the state. So, they're still licensed and they're licensed as PAs, but there's really not a distinction on our end. It's just what we see is in the system is just PAs.
And then one final question from me, it might be helpful for the council. Do you mind just walking through the difference between an anesthesiologist, a CAA, and a CRNA? And what maybe job duties are different, qualifications, et cetera?
Sure, I can give you the basics. I'm gonna start with the anesthesiologist. I mean, their training is so much more advanced than AAs and CRNAs and PAs. I mean, they have 4 years of undergrad, and they have 4 years of medical school with all the hours of training and didactics, and they have a year of internship between that year or two, then 4 years of anesthesia training, and then years of specialty training if they're doing cardiac or pediatrics. You're talking about 12 to 15 years of training for anesthesiologists. So they're definitely very, very qualified. AAs and CRNAs have like hours. We go for about 2,600 hours of clinical training, 600 didactic. That varies a little bit between the schools, but we are trained specifically, of course, in anesthesia. AAs typically are pre-medical, so we go to a four-year undergraduate program, and typically have a Bachelor of Science in biology or chemistry or physics or something like that. So we would be applying to medical school at the same time applying to AA school. And so we'd go straight from undergrad without other experience into the AA program for 2.5 years. Now, CRNAs, which I can speak generally about, they have a nursing bachelor's degree, which I believe is I think it's a 2.5 to maybe 2 year program. I can be wrong about that though. And then they have that's been a year in the clinical ICU. They get trained for their nursing, and then they have a 2.5 year program, which I believe now is a 3 year program to become a doctorate in nurse anesthesia. The hours are kind of about the same for AAs and CRNAs, except the fact that CRNAs do have a year of ICU training prior to them going into CRNA school. But one of the differences I see between CRNAs and AAs is that there's about 12 AA schools, and the criteria is very, very stringent to get into them. About 120 CRNA schools. There's a lot of opportunity to get into CRNA school, but they're still great. Everybody's very qualified, but anesthesiologists are definitely the most qualified of the three. Did that answer your question?
Yes, thank you. Does anyone else have any questions? Okay, thank you so much for your time. We appreciate it. We'll now move on to our third person, which is Zach Gilbert with the Office of Planning and Budget, who will present some research done on the different states that are licensing anesthesiologists currently and some of the similarities and differences. I'll also take this time to say, if you're here for public comment and want to speak during our next agenda item, please put your name and organization in the video chat, and we will call each person in order. Thank you.
Alrighty, I'm going to share my screen real quick. Okay, so there are 15 states with state law providing for the licensure of AAs. Utah is the most recent state to pass a state law that licenses anesthesiologist assistants. This happened back in March of this year. Georgia has not passed a state law solely focused on the licensure of AAs. Washington, D.C. and the Territory of Guam also provide for licensure of AAs. There are also 4 states that have the practice of anesthesiologist assistants available. These are through delegated authority. These 4 states are Kansas, Michigan, Pennsylvania, and Texas. All states have the same educational requirements for this licensure, which is a master's level AA program. Also, a successful passage of the NCCAA exam. Kentucky, Alabama, and North Carolina all have annual renewal requirements, while the other 11 states have biennial, or while the other 12 states have biennial renewals. License fees range from the lowest of $25, which is the state of Missouri, to the highest, which is $300, which is the states of Georgia and Kentucky. The average licensure fee of all the states combined is $187. The number of AAs that can be supervised by one anesthesiologist can range throughout the country. The states that have a maximum of no more than 4 AAs being supervised concurrently, those states are Alabama, Colorado, Florida, Indiana, Missouri, North Carolina, and Georgia. Places that have a maximum of no more than 3 AAs being supervised concurrently, that is New Mexico and Washington, D.C. And then the places that have a maximum of no more than 2 AAs being supervised concurrently, those states are Kentucky, South Carolina, Wisconsin, and the Territory of Guam. AAs are allowed under direct supervision to prescribe non-controlled substances in 3 states. Those states are Alabama, Georgia, and Kentucky. For Kentucky specifically, if the AA is also a licensed PA, then they can prescribe non-controlled substances. For educational requirements, each of these programs are master's level programs, which require a bachelor's degree with an emphasis on pre-med work. A minimum of 3.0 GPA out of 4 is required, as long with an additional laboratory experience during undergrad studies, which range to about, the AA programs range to about 24 to 28 months in duration, which allows students to complete well over 2,000 clinical hours in operating rooms of hospitals and surgery centers. Students are required to take certain anesthesia-related courses such as patient simulations, principles of airway management, principles of monitoring and instrumentation, and clinical anesthesia. Graduation requirements for these programs typically involve a residence of 7 semesters, satisfactory completion of coursework, demonstration of ethical and moral behavior, and completing more than 2,000 clinical hours. And on this next slide, I have a map of all the states who have state laws that are solely focused on AAs and their licensure. And it gives you kind of like a timeline of sorts that shows you, which states have adopted these laws and when they have. And as you can see, Utah is the most recent, and Alabama is the oldest one to this list. That's all I have.
Thank you. Okay, if there are no questions, we will move on to public comment. Daniel Dorsey, I have you listed as first if you have any additional comments you want to make on the legislation.
Yes, just want a couple of things. We do currently have, so for the framework of licensing PAs, which includes both physician assistants and anesthesiology assistants in the state, there is a committee that our board has. It's the Physician Assistant Advisory Committee, and it's composed of I think 3 or 4 PAs. One AA is on there, as well as some of our board members, and also the PA ex officio member that is a part of the board as well. And they are the ones that review all the applications and for both for PAs and AAs that want to get licensed as PAs in the state. And so so there is a little bit of representation, of AAs, and having someone on that committee that is familiar with that process and familiar with the credentials and the educational requirements to review those applications. But as Senator Huffstetler noted, there is not an AA that is officially on the board as a board member. But there is someone that is in the review process of those applications. Did y'all get the fiscal note for this?
I believe a fiscal note was not conducted since the bill was dead. We did decide to consider it for the GORRC process, but a fiscal note has not been done.
Okay. There was one thing. So if implementing this bill, the way we currently have it is we have everyone licensed as a PA. There's no distinction between AA or PA in our computer system. So and there's not a way we can query to isolate out just the AAs and separate them from the PAs. So that would be something that we would have to navigate if implementing this bill. How would we go about being able to isolate those individuals and ensure that they had the credentials necessary to meet what's in the proposed bill? I will say what's in the proposed bill is basically what we have already in state law for PAs. So there's really not much of a difference. It's just really just kind of classifying them, the ones that are actively practicing as PAs. But that would be something that we would have to navigate is how to separate those out. And we're trying to work through that and come up with ideas for that. So.
This is Representative Cooper. I mean, we have an IT department, don't we? And I mean, wouldn't you let people know when it was time for them to renew their license that they needed to identify? And that's how you would separate them out. It would be self-identification.
That's certainly a way to go about doing it. The thing is it's the license is good for 2 years, so to capture all of those individuals, it would be a 2-year rollout. So yes, we could do it that way and capture all the people that are currently licensed and make sure they get into the right category. But it would just take 2 years of people going through and renewing their licenses. But anyone moving forward.
Well, but doing it over a 2-year period is not something that is unusual for us, or to have a period where people opt in. So that's not an unusual, out of the way or unusual thing to do.
Okay. And they, at the end of the day, they're still licensed. So there's still a way for us to ensure that the public is protected and patients are safe, and when seeking care from that individual. So, but yeah.
Okay.
Does anyone have any questions? I'm happy to answer from an agency perspective.
I guess going back, I can't remember if we addressed this already, but do you all have any sort of complaints that you have taken on any confusion between the PAs and the AAs and any confusion that's caused?
Not that I'm aware of. Yeah, it's most people when they go, they know PA and they know that that's what they're licensed as. So
I think one of the problems that we have, and we have passed bills before. I mean, when you get into the medical issue, we're a little different from all the people that are on this, the departments that are in on this. It's not like plumbers or electricians and all. And one of the problems that we've had in the past is that patients don't know who's taking care of them in the hospitals. And that's from aides up to knowing whether somebody's an RN or not. And we've had to pass laws about that. But in the operating room, I mean, you don't wear a big name badge and all. And I would think that the biggest confusion would be, and I know because I ask if anybody's going to do anything to me, I want to know whether it's the anesthesiologist or it's a PA or it's a nurse midwife, a nurse and whatever they call themselves, nurse anesthetist. And that they don't really know who's taking care of them or who is going to administer the anesthesia. I think they would often probably think they're dealing with a doctor when any of these people come in these auxiliary areas in the preparation of getting ready to have some kind of surgery. I mean, I know that that's a problem for a fact because, you know, we hear it. It doesn't reach the level of going as a complaint to the medical board. It's just a confusion among patients. And it's one of the reasons that we've tried to, you know, pass bills to have people have to identify themselves. And especially with all the doctorates coming now, and you can be a doctor of nursing, you can be a doctor of physical therapy and all. And if on your thing you just say Dr. So-and-so, in the medical setting, they often think that's an MD. So it is a problem, but more a patient problem than I think that you would get it back to the medical board. It wouldn't raise, that kind of complaint would not raise to the medical board's level.
A lot of hospitals and healthcare facilities have done a good job of identifying with like color coding name badges, which helps identify, you know, what the level at which, you know, is it a doctor or is it a nurse or, you know, and so that is one way that patients are able to easily identify the level of training associated with an individual that's in the care room.
I think you're probably new to the medical board, as far as I know, after LaSharn's death, but probably that any of those clarifications have come from the fact that we've passed bills because we needed to have that clarification.
Mm-hmm.
Yes, Kelly, go ahead.
I just have a question about that. So, oh, am I frozen? Y'all are all frozen. Oh, nope. Hopefully you can hear me. Okay. Yeah. Clarification, because it is true. When I've been into surgery, I don't even know a name of the anesthesiologist. Right now, as they're putting that on my face, they say I'm nurse anesthetist Ron Dudley. But at that point, it's too late. But how does this help the patient? How does this piece help the patient? Because I would love to have a list beforehand of who's going to be taking care of me. And then I can go look. At that point, it would be helpful if I could just look at an anesthesiology board and say, okay, is it someone on this list or do I have to go look at another one? So I'm just curious how what we're proposing today helps the patient in that matter.
I can probably speak a little bit to that. And it's the whole gamut, kind of like Representative Cooper was saying. It starts with name recognition when you're in school, with the public knowing that there are anesthesiologist assistants out there and what their training is. But from my perspective, when you're talking about this new bill and this new Practice Act, is to maintain the standards for our anesthesia care. I want there to be specific standards for anesthesiologist assistants. And I think maintaining those high standards for a specific license would be very beneficial to the patients. It's not always just knowing who's taking care of you, but if you do see it's an AA, you'll know who it is, you'll know what they are, and you'll know that they have a license that's specific for them, and that it's being maintained at a very high standard. And I'm not saying that PAs are not, but it's still a specific anesthesia training versus a generalized training. And I think that's where the patients are going to be most helped.
Thank you very much.
Sure.
And while it may not be helpful when you're in the operating room and they're putting on the mask, but one thing that you can do beforehand, if you do know about the providers that are going to be rendering care to you, our website has a search feature where you can verify the licensure credentials of the individuals, with their license and what type of license status they have. Are there any disciplinary actions based on that license or public board actions that are there? So that is one thing that, if you know the providers beforehand, you can research that and as a patient.
Since they're licensed as PAs, do you put out there on that place you go on the board to look at this, does it delineate that these are anesthesia assistants? Or no, it just says they're just PAs?
It just says PA.
Okay. Well, yeah, PAs do a lot of things, but being put to sleep is pretty dangerous if you don't do it right. And so there would be no way that they could look and tell the difference of that this one's going to put them to sleep.
What you could do is you could look at the specific job description that each physician assistant has a job description that's associated with the license that basically talks about what they can and can't do as a practicing PA, and the job description will say whether it's a AA job description or a PA job description. But you got to click all the way on the PDF itself, and it's a static PDF. So it is a little bit of clicking to get to that, but you can see what that individual is allowed to do.
Which it makes it harder for transparency, which is one of the things that we keep talking about in the legislature. So, sorry, it's all the confusion and things that we deal with on nursing and medicine and all the different groups is coming out. So.
Appreciate that additional insight. Thank you.
Thank you.
Is there anyone else who would like to speak on the bill? Okay, seeing none, just a few housekeeping items. Our next meeting is scheduled June 29th from 1 to 2. Representative Cooper will look into the meeting format to see if we can find a format that works. So you'll be able to take that.
Okay. If you can't, and it's going to be a problem, I can hopefully use this office again.
Okay.
All right.
Thank you. Our draft meeting minutes will be sent out to council members in the next week or so for review. We will approve those our next meeting. So if you have any edits that you want to suggest to us, please let us know when you get those draft minutes. A recording will be posted on our website of this meeting and future meetings. So if you need to refer back for some additional details, that will be posted shortly. I believe that was it. So unless anyone else has any further comments, I will motion to adjourn, and we'll need a second. Second. Thank you so much. Have a great day.
Thank you.
Thank you.
Bye.
Thank you.